engineer. So now I would like to introduce our esteemed speakers this evening. We have Dr. Mary Pat Kuig, who is a senior executive who serves in the role as a senior executive at the Executive Department of Veterans Affairs Office of Nursing Services. In her post at the VA, Dr. Kuig advised the Chief Nursing Officer on public health emergencies. Dr. Kuig served as the National Program Manager prior to for the RN to Transition Practice Program and was responsible for developing the infrastructure of this program and implementing it in 141 medical centers. She also served as the Chief Nurse Officer and Assistant Surgeon General for the United States Public Health Service from 2000 to 2005. She retired at the rank of Rear Admiral. She is now currently an Associate Professor of Nursing at the college, and she is the Director of the Disaster Preparedness and Pandemic Center. Welcome, Dr. Kuig. I would also like to introduce the Acting Associate Director of the RN to Transition Practice Program at the Veterans Administration, Dr. Shelley Roth. Prior to this role, Dr. Roth was the Chief of Education and Design Learning Officer in the Sioux Falls VA healthcare system. She has championed many education initiatives as well as leading efforts in Sioux Falls VA healthcare system in achieving pathways to excellence. Dr. Roth earned a Bachelor's of Art in Nursing from Augustina College, a Master's of Science in Nursing from Walden University, and a Doctor of Nursing Practice from Grand Canyon University. I would like to welcome Dr. Roth to this presentation. I will now turn the presentation over first to Dr. Kuig and then to Dr. Roth. Thank you this evening for sharing your expertise with us, and welcome.
Thank you very much, Dr. Kelly, for that warm welcome. And Dr. Roth is going to start us off. We're going to do the presentation in two parts. Let me get to the screen where the slides are. Okay. Can everybody see the full screen of the? Yes. Okay. I see head nodding. Yes. All right. I'm going to forward the slides for Dr. Roth. So Dr. Roth, please begin.
All right, thank you. So good evening, everybody. Thank you for the opportunity to share about the Department of Veterans Affairs RN Transition to Practice program. Next slide, please. So a quick disclaimer before we get started is that the views presented this evening are our own and do not represent the U.S. government, Department of Veterans Affairs, or the College of Nursing, the University of New Mexico. Next slide, please. The objectives for this presentation include summarizing the Veterans Health Administration current projected need for registered nurses, describing the challenges of the newly graduated and licensed registered nurse in the United States, discussing the Veterans Health Administration RN Transition to Practice Residency Program, and explaining the initiatives and infrastructure to support the RNTTP Residency Program. Next slide, please. The Nursing Strategic Workforce Plan is a 10-year nursing workforce plan with the focus on 4 pillars with specific strategies to ensure a strong nursing workforce to meet the 4 statutory missions of VA. 4 pillars outline the objectives and focus of the plan with veterans at the center. These pillars are optimizing and informing nursing practice, strengthening the nursing workforce, reimagining lifelong learning and career development, and inspiring an industry-leading culture. Today's presentation will focus mainly on Pillar 2, strengthening the nursing workforce. Next slide, please. Nationwide, 1 in 5 RNs are eligible to retire within 5 years, and the American Hospital Association projects a shortage of 500,000 RNs by 2026. The Veterans Health Administration fiscal year 2022 to 2026 nurse hiring total projections by discipline are outlined in this figure. To try and stay ahead of the projected shortage, VHA Nursing has a robust goal of hiring 15,500 nurses each year for the next 5 years for a total of 77,500 nurses. In addition to this robust plan, ONS leadership is recommending that 10 to 15% of the RN graduate workforce be new graduate RNs. This will impact our mean RN age and impact retirements anticipated as baby boomers all reach retirement eligibility by 2030. Therefore, transition to practice residency programs will be instrumental in bridging new nurses into a professional nurse role. Next slide, please. Transitioning from nursing school into practice is difficult, especially in today's day and age. Historically, there has been increased turnover of new graduate RNs, with many leaving the profession. Recent literature continues to support the need for transition to practice programs for new RNs, citing a gap between academic and clinical practice. Another important impact is variation in education preparation of the new RN. In the first year of professional experience, as much as 35 to 60% of new RNs leave the profession, citing an unwelcoming practice environment, job-related stress, lack of confidence, and support. The increased turnover has resulted in increasing costs to facilities as they need to replace these nurses while also managing the work and recruiting and onboarding a replacement. Cost of turnover has been estimated to be approximately $40,000 for a staff RN, but it can range anywhere from $28,000 to $52,000. Next slide, please. In order to overcome all of the challenges and reduce turnover of new nurses, there needs to be a seamless progression of support. The transition to practice programs are essential to ensure new graduates are transitioned from their academic role to a professional nurse role. This progression mirrors Benner's novice to expert theory. The novice to expert theory explains that nurses develop skills and an understanding of patient care over time from a combination of a strong educational foundation and personal experiences. The theory describes support nurses may need as they develop along the continuum of experience. There are 5 phases a nurse may pass through as they acquire competence: novice, advanced beginner, competent, proficient, and expert. Next slide, please. Recognizing the need for a transition to practice program, the Office of Nursing Services piloted a 12-month RN transition to practice residency program at 8 sites in January of 2009. The pilot resulted in an initial 98.6% retention rate and demonstrated a cost savings of $1 million during that 1-year pilot. The Veterans Health Administration then implemented a mandatory RN-TTP program in November of 2011. Support for the RN-TTP program was based on growing evidence highlighting the challenges of new graduate RNs transitioning into practice, including high turnover rates. The original directive required VHA facilities establish a structured transition programs for all levels of entry RNs, utilizing the flexible VHA 12-month RN transition to practice program. Initial resources that supported the program included an RN transition to practice program coordinator, nurse managers, staff nurse preceptors, and a program guide and surveys. The role of the RNTTP program coordinator is to coordinate and provide programmatic guidance for the postgraduate nurse, preceptor, mentor, and other transition to practice program support team members. Ensuring completion of evaluation forms from postgraduate RNs and preceptors, as well as collating and submitting the data to the Office of Nursing Services as requested. The nurse unit manager is responsible for ensuring each postgraduate RN is assigned an RN preceptor and mentor. The postgraduate RN has every opportunity to complete the program. So making sure that the RN and the preceptor have adequate time to participate in and to successfully complete the program. And then the facility staff nurse preceptor is responsible for guiding and transitioning of the new postgraduate RN to the role and responsibilities of the unit, facilitating the entry of new staff to the workplace, and introducing the new staff to other members of the interdisciplinary team. Next slide, please. In April of 2019, revised Directive 1077, Veterans Health Administration Registered Nurse Transition to Practice Residency Program was approved. The revised directive now states that it is a VHA policy that every VA medical facility that hires new graduate RNs in their first licensed role, or RNs with less than 1 year of professional experience, establish or collaborate with an established structured 1-year RNTTP residency program that is based on the Commission of Collegiate Nursing Education Standards for accreditation of entry to practice nurse residency programs. Next slide, please. The RNTTP residency program mission is to bridge the gap between nursing academic education and professional nursing practice. It is designed to support RN residents as they transition from an entry-level advanced beginner nurse to a competent professional nurse. The overarching goal is safe, high-quality care for our veterans. The mission serves to provide a program which will further develop effective decision-making skills related to clinical judgment and performance, strategies to incorporate research-based and other evidence into practice, clinical leadership skills at the point of patient care, and to formulate an individual care plan that promotes a lifelong commitment to professional nursing. Next slide, please. The RNTTP program assists the postgraduate RN in the transition from academia to a complex environment. The RNTTP program consists of a comprehensive 12-month curriculum built upon the CCNE standards related to clinical, leadership, and professional dimensions. Additionally, veteran-centric content is reviewed during the RNTTP program. The program contains both didactic and experiential learning components. Each postgraduate RN is assigned a preceptor who is an experienced RN who has completed preceptor training. Next slide, please. The RNTTP residency program curriculum has 2 primary goals that align with the Commission on Collegiate Nursing Education Standards: management and delivery of quality veteran-centric care and professional role and leadership. The elements for nurse residencies that fall within the management and delivery of quality person-centered care include quality and safety, person-centered care with programs and activities within the curriculum that contain veteran-centric topics such as suicide prevention, post-traumatic stress disorder, homelessness, traumatic brain injury, opioid and alcohol addictions, depression, military culture, military sexual trauma, and spinal cord injuries. Management of patient care delivery, management of the changing patient condition, communication and conflict management, informatics, and healthcare technology. The elements that fall within the professional role and leadership include professional development, performance improvement and evidence-based practice, ethical decision-making, stress management, and business of healthcare. Next slide, please. VHA strives for a healthy work environment for all of its employees. Healthy work environments lead to more engaged nurses, decreased burnout, lower turnover, and better patient care. The AACN standards of a healthy work environment include skilled communication, true collaboration, effective decision-making, appropriate staffing, meaningful recognition, and authentic leadership. Many of these standards should sound familiar, as most of them mirror the CCNE accreditation standards and are the foundation of the RNTTP curriculum. RNTTP programs provide dedicated didactic and clinical time for the new graduate to transition from novice to expert in a safe and healthy work environment. Next slide, please. Experiential learning is an engaged learning process whereby students learn by doing and by reflecting on that experience. Many RNTTP programs include experiential learning components such as case studies, simulation, escape rooms, and role play. Next slide, please. RNTTP residents are paired with a preceptor through their program. The preceptor guides, coaches, and mentors the new graduate RNs supporting their transition into practice. The Office of Nursing Service contracts with Elsevier to provide the Elsevier-Mosby 3.0 preceptor course for all preceptors. Leveraging this course provides preceptors the foundational knowledge and skill needed to assess and promote nursing knowledge, critical thinking, and competency among our new graduate nurses. Next slide, please. Specific benefits for the resident are outlined on this slide. Research has shown an increase in competence, confidence, and organizational skills, improved nursing skills, and use of evidence-based practice, improved communication and leadership, and positive socialization with other professionals. Next slide, please. There are many organizational benefits tied to the residency program, including increased employee satisfaction, increased retention, increased access to care for our veterans, a standardization of transition for new graduate RNs into practice, which supports a high reliability organization and nursing excellence, and it promotes expansion of the Veterans Health Administration nurse workforce and professional development of future nurse leaders. Next slide, please. Identified as a benefit for both the resident and the organization is professional development. Professional development is a key element of the nurse residency program by aiding the new RN to form a professional identity. Opportunities that RNTTP residents pursue include becoming an active member on an organizational committee, serving as a preceptor, mentor for future nurses, seeking certification, and continuing formal education. RNTTP specifically addresses career plans for new graduate nurses and highlights the many opportunities and benefits of a Veteran Health Administration nursing career. The RNTTP residency program educates and supports residents to be lifelong learners who are committed to veteran care. Next slide, please. The establishment of the RNTTP residency program has provided Veterans Affairs the ability to recruit and retain nurses that are prepared to provide high quality, safe, veteran-centric care. As we just reviewed, research has shown many beneficial outcomes to the new RN graduate and the organization that have RN residency programs. Next slide, please. RNTTP also ties into some of the other initiatives and strategies throughout VHA. One of those initiatives is being a high reliability organization. The RNTTP residency program has a strong connection to the foundational HRO pillars. Leadership commitment focuses on committing to the goal of zero harm. The RNTTP entry to practice programs allow dedicated time for the new nurse to transition from novice to expert in a controlled, faculty precepted, supervised environment, empowering them to speak up when they have questions, see risk, or have an idea for improvement. Culture of safety. RNTTP gives new nurses the opportunity to see operations in multiple care settings, voice their ideas, and share safety concerns without the fear of reprisal or punitive action. And continuous process improvement. RNTTP focuses on quality improvement and evidence-based practice. While some new nurses may be hired with knowledge of improvement methods, all residents take part in an evidence-based practice or quality improvement project with a goal of developing improvement skills the nurse can apply in practice. I will turn it over to Dr. Kuig.
Thank you very much, Dr. Roth. Can everyone hear me okay? Great, see heads shaking. So this part of the presentation is going to focus on a brief history of the program, the infrastructure to support the program, and then the current initiatives that are underway to further support the program. So this timeline shows the start of the program here in 2009 with the pilot, and then in 2011 when the first directive was issued. In 2015, there was a report by the U.S. Government Accountability Office that was looking at nurse retention within the VA, and I'll speak to that further in the presentation. Also in 2015, a dedicated 0.5 FTEE was implemented for the program manager position. In 2019, the revised directive was issued, and I'll review some of the components of that. Also in 2019, I was very pleased to see that there was a full-time dedicated position for this national program. That had been one of the recommendations. You will all remember what happened in March of 2020 with the pandemic. And at that time, the directive was suspended. It was reinstated in 2021. Later in 2021, there was an initiative related to funding for the program. In 2022, there was a request for $4.6 million for expansion. In 2023, the executive decision memo, which I will discuss in further detail, and then I'll also provide information about the revised directive, which is due for next April. So in terms of infrastructure, The Field Advisory Committee is comprised of RNTTP residency program directors from across the country. The purpose of the FAC is to provide expertise and advice to the Assistant Undersecretary for Patient Care Services, who is also the Chief Nursing Officer, and the National Nursing Leadership Council on the RN Transition to Practice Residency Program. The FAC serves in an advisory or recommending capacity to the Office of Nursing Services Leadership, the ONS Program Manager, the National Nursing Leadership Council, and the Chief Nursing Officer. Community of practice. There was a need to provide ongoing training and support for the facility program directors. Currently, there are monthly education calls, mentoring sessions, and open forums. Any of the program directors can join and ask questions and get advice from their fellow program directors. There are also longer education sessions at dedicated national training. Recently, there was a 3-hour session that was held to review one of the accreditation standards related to program evaluation. Data collection. In 2011, when the program officially started, there was a data collection option, but it was not managed centrally, and the database was split between 2 servers. A request was approved for a centralized database that would be created and managed by the Veterans Health Administration Support Service Center Capital Assets, otherwise known as VSSC. The database was designed with input from RNTTP residency program directors and other experts. Surveys. The program uses 3 surveys to monitor residents' progress, capture information on confidence, and get feedback on the program. The resident competency assessment was revised in 2017 to reflect the new key elements of the Commission on Collegiate Nursing Education accreditation standards for entry to practice nurse residency programs. In a collaboration with one of the VA's research centers, the survey has undergone psychometric testing and was shortened from 100 items to 70 items. The end of program evaluation survey will undergo psychometric testing in fiscal year 24. And finally, the listserv, which is another forum for sharing information and from the Office of Nursing Services, but also to share information and ask questions amongst the program directors. Turning now to the current initiatives. Dr. Roth can tell you that there has been hours of work on the executive decision memo for funding for the residency program director and administrative support positions. This strategy will deploy funds to the Veterans Integrated Service Networks, the VISNs, which are like the regional offices within the operational structure, based on the needs and strengths of the programs. Funding will secure, at least the last version, funding will secure 166 field-based infrastructure staff, 83 dedicated program directors, and 83 administrative support personnel to support the increased volume of entry to practice nurses. Dedicated positions ensure the effective utilization of the specialized knowledge, skills, and abilities to promote the proposed program expansion to almost 1,000 residents about 250 graduate nurse technicians and 250 student nurse technicians. Graduate nurse technicians are graduate nurses who have successfully completed their full course of nursing in an approved nursing school and whose licensure or registration is pending. They may be appointed as an employee on a temporary, full-time, part-time, or intermittent basis. Student nurse technicians are students enrolled in an approved nursing school that's nationally accredited by the CCNE or the ACEN and may be appointed as an employee for a period not to extend the duration of the individual's program. These are also considered pipelines for helping to increase the number of nurses within the Veterans Health Administration. This is the first directive. I'm not going to review this because Dr. Roth did that in her presentation and I had forgotten about that, so included this slide. I would like to talk a little bit about Directive 1077, which was the one that was approved in 2019, and also talk a little bit about the extensive review process. The directives are reviewed on a 5-year basis. The process takes about a year. Within the office that is responsible for the implementation of the directive is revised, it's approved, and then it goes to the policy office for review and management. That process was instituted probably 5 or 6 years ago when it was recognized and acknowledged that there was the potential for multiple policies and there needed to be a central office to review all of the policies to make sure there was no duplication. Once the directive is approved for agency-wide review, it's distributed, and there is an option for anybody who wants to provide comments. All comments have to be addressed with responses to the policy office. And when we were revising the directive, there were 70 comments, and I had to individually address each one of those comments. Then the directive goes to the final review for the senior leadership. There were 2 major changes and a couple of other changes. There were increased responsibilities for the principal deputy undersecretary for health being responsible for authorizing the policy for the management and oversight of the program. And then under the deputy undersecretary for health for operations, being responsible for providing support to the VISNs or the regional areas for implementing the program as it's established in the directive. And Dr. Roth mentioned that a program had to be established or you could collaborate with an established program. And this was done to address the needs of rural facilities that are smaller and don't necessarily have all of the resources to implement a complete program. And it was also clarified that the program should be based on the CCNE accreditation standards. As I mentioned, the directive is currently under review, and there are a number of recommended changes. It was clarified that the data collection should be consistent with the CCNE standards, that it was clearly stated that there had to be a process to define, collect, analyze, develop, and disseminate an action plan based on program data, that data needed to be collected using the centralized platform that had been developed and using local reports that would include program completion data, resident retention data, program satisfaction data from residents and other stakeholders, evidence that RN residents have achieved the competencies, and that would be completed by the evaluator or preceptor. Any other program effectiveness data as determined by the facility program, and requiring a full-time equivalent for a program director if the program was in planning stages or was new. Previously, the recommendations for the FTEEs for the program directors was a recommendation, and there was feedback and support from the Office of Nursing Services and the other field program directors that that should be required. And also ensuring that the associate directors for patient care services, who's usually the chief nurse officer, would ensure correct coding so that there was accurate data in the database. And there was one other requirement, and that was that new graduates participate in the program. Believe it or not, we did get a question one time about whether or not nurses had to participate. So we strengthened that language. Okay, moving on to program evaluation. There have been several surveys and reports, and I'm going to talk a little bit about what is currently underway. I mentioned that in 2015, the Government Accountability Office issued a report. They were looking across all of the VHA's programs for nursing, recruitment, and retention. They wanted to examine the extent to which VHA oversees the programs, and then they issued their findings in a report. And I'm only including the findings here that were related to the RNTTP residency program. First was that a lack of funding for a program that is financially and staff resource intensive. We know that and had been trying to address that. One finding that I did not know was that some medical centers were deciding to hire experienced RNs only due to the financial burden associated with the initiative, and that some medical centers in rural locations found it difficult to implement the program because of a lack of available instructors for the required training. And hopefully that has been at least partially addressed. In 2017, I conducted a survey of the medical centers regarding the implementation of the directive. The overall response rate was 75%. Of the 106 who responded, 101 stated that they hired new graduates. And of the 103 that answered, if they hired, do they have a program? 88% said yes. And then the 90 who responded to the question about if there was a program, did you have a designated director? 83 responded positively, and that was 92%. Now, this next slide was really very alarming. This question asked, if your RNTTP program director or program has a designated director, what % of the time is for RNTTP? And the answer is that almost 50% said that they spend 0 to 20% time on the program. And I came to learn that many of the program directors had multiple titles like nurse educator, unit educator. And so this was really important information in terms of evidence for why there needs to be central funding for the program. In 2018, there was a study that was conducted with the VA Ann Arbor healthcare system. VHA has a number of research facilities, and they are a number of research centers which focus on different aspects of veterans care and health systems and quality and implementation science, in addition to other things. They did a qualitative assessment of factors affecting RNTTP residency program implementation. They had some quantitative data, and they also did 19 interviews. And the factors that affected implementation were materials and support from the Office of Nursing Services, what was going on at their own facility in terms of the organizational structure and resources, the program requirements, and the program outcomes. All right, moving to 2023-2024. There's been a lot of activity in this area related to program evaluation. There is a survey that was developed to, again, look at the fidelity of the program implementation. It's based on the RE-AIM framework, which looks at whether or not you've reached your target population, how effective the program is, whether or not the program's been adopted, whether it's been implemented, and whether or not it's been maintained or sustained. Now, at the same time this survey was being developed, other organizations like Workforce Consulting, that keeps a lot of the data on the nursing workforce and the needs, was developing a survey. The nurse practitioner group was interested in surveying the field, as were several others. We were able to keep our survey separate, and we had to get it reviewed by an office that looks at all of the surveys that are ongoing. And fortunately, we had done such a good job with focusing just on the program. There was only one question that we had to delete that was being included in the other survey. So we hope that the survey will be ready for distribution within the next month or so. The VHA has a program called Research Evaluator in Residence, and a number of the ONS staff and experts discussed a comprehensive program evaluation, in addition to looking at fidelity of the program, also looking at, from a more qualitative perspective, what were the program director resource needs, what was needed as far as facility support, what were drivers of program enrollment, and any association between director facility resources and RN resident retention rates. And so the survey that I just mentioned will be the quantitative portion of this survey. There is a PhD trained nurse who has been selected to manage this comprehensive program evaluation. She earned her education doctorate, and her thesis was on factors related to the RNTTP residency program, I believe at her facility. So we are very excited. That work has just begun and is expected to be completed, I think, in either 6 or 9 months. And another contribution to the program evaluation is there is a group that does evidence syntheses. And we were able to get approval for an evidence synthesis to look at the evidence for transition to practice residency fellowship programs and to review implementation characteristics to help inform the implementation of these programs. We do know some best practices, which I'll mention just very in a little bit, but we thought it would be helpful to have another review related to the best evidence. And that work is supposed to be completed, I think, within the next month or two. So that could also help inform the new directive. Related to the survey psychometric testing, Dr. Roth mentioned some of these. The resident competency assessment that was initially developed had not been validated, and she mentioned that we collaborated with one of the research groups. They've conducted their review and were able to decrease the number of items. The resident completes this survey at 1 and 12 months, and then the evaluator or primary preceptor completes it at 1, 3, 6, and 12 months. That provides a great opportunity for the staff, the preceptor, to be able to monitor how the nurse resident is doing in terms of their transition process. The Casey Fink is a well-validated tool that has been in use for a number of years. It primarily looks at nurse confidence. That survey is completed at 1, 6, and 12 months. And then the end of program evaluation. Currently, feedback just from the residents is being collected. That form still needs to undergo psychometric testing, and that's planned for the next fiscal year. And then that form will be expanded to other stakeholders, and that's part of the CCNE accreditation requirements. Keeping an eye on the time here. Best practices. Dr. Bratt published an article in 2013 that identified best practices for nurse residency programs, starting with securing stakeholder support when the program begins. VHA had the directive, but we've encouraged the program directors to put together business cases for their facilities. So the senior leadership can see how many nurses they have, how many are eligible for retirement, and get a broader picture of their nursing workforce for their facility. Sufficient and appropriate resources. We have been advocating for funding for the program for a long time. So I'm really pleased to see that the executive decision memo is moving forward, and hopefully that will provide resources for that. Building the program on best evidence. I think you've seen through the description of the infrastructure that we have tried to focus on that. Another best practice multi-stage program, both short and long-term. The program requirement is for a year. We have preceptors and there are education sessions. You've heard about the evaluation plan and our measurement outcomes, and then program sustainment. So for the future, a new full-time associate director, that process is underway, and hopefully that announcement will be made within the next couple of weeks. The Office of Nursing Services was able to secure a full-time program support person and a full-time data analyst, maintaining the initiatives, tracking the initiatives, looking at the data platform, continuing to improve that as needed. And then once all of these evaluations have been done, looking at quality improvement, what changes could be made to improve the program, and then looking at what kind of research could be done with all of this data that is being collected. So in summary, our transition to practice residency programs are beneficial both for residents and for organizations. VHA has been a leader and an early adopter of RNTTP residency programs. It's important for program evaluation, for outcomes and quality improvement, and then funding to support the program. And then we have a lot of references here. I think I've got 3 pages. And that is the end of our presentation. I'm going to stop sharing here.
Well, thank you, Dr. Kuig, and thank you, Dr. Roth, for all of your hard work on your presentation. We do appreciate it. For those of you who don't know me, my name is Marlena, and I am the Alumni Marketing and Outreach Officer for the College of Nursing, and we're now at the Q&A part of our program. You can write your questions in the chat and I can read them to our presenters. You may also virtually raise your hand and ask the question that way. We'll alternate between both and try and call in as many participants as we can. So, does anybody have any questions for our presenters? Dr. Kelly.
Dr. Kuig, or Dr. Roth, when you got your factors back with the less than 50% support for the program directors at the treatment at the hospitals because they were multitasked, what was the rationale that was provided? Does each VISN gets money to support this program? Why doesn't the money go down to, as I would say in the Navy, to the deck plate, to the people who are doing the work? What was going on in the system, and how are they going to be able to improve it with centralizing, the Office of ONS? How are they going to know that when they send the money down through the VISN to the hospitals that the programs will be executed and the program director will have more time to do it?
You want to take that one?
I sure can. I'll start. So when that survey was completed, the directive actually had a recommendation for the FTE, so the full-time equivalent program director. And then of course, at that time, there was no centralized funding. So facilities were doing their best to be in compliance with the directive. But even though they were not maybe taking on what the recommendation was for the amount of time for that program director based on their program size. So that's really what we're looking at with the revisions to the new directive. We have made it a requirement for the amount of FTE based on the program size, the number of residents. And then if our executive decision memo goes through and is approved, then the VISNs will be able to allocate specific funding for those program director positions. So that's kind of the difference between where we were at that time and where we're trying to go.
Right, but what's the
Anything to add? Oh, go ahead.
Yeah.
I just wanted to know what was the feedback loop that even if they do get the money and even if you do have the directive, is somebody going to audit them to make sure what's going to go on?
Yeah, so they would be audited from the Office of Nursing Services to ensure compliance with directive and with the funding, and they have to report back what they're using their funding for.
Okay, thank you very much.
Yes, thank you.
Do we have other questions from the audience? Yes, Dr. Damron.
Yeah, thanks to Dr. Cook and Dr. Roth, very interesting. Good, appreciate all the facts and such that were in there. As always with these nurse residency programs, funding's always an issue, whether it's in the military or not. But yet you look at all the graduate medical education residencies are very different, but still you look at the amount of money that's spent on transitioning physicians into practice from the end of medical school and of course, I mean, they have more standardized ways of doing it. The GME is much more standardized nationwide. Of course, we can't even get our clinical hours all aligned across all of our training programs and nursing across the country. But I was just curious if y'all have any feel for the amount of money that goes into the VA, TTP programs compared to something comparable in medicine. I'm just curious if y'all have looked at that or any comments on that.
That isn't something I have been part of. We've specifically been looking at the RNTTP program with the expansion and having to hire, the 15,500 nurses per year that we're estimating we will need within the Veterans Health Administration. I do know that there has been some initial collaboration work with the Office of Academic Affiliations, which is responsible for a lot of the graduate medical education residency programs, and how we can collaborate further to, expand not only the GME funding, but also the nurse residency funding. But I don't have a specific number for you because I haven't been part of that comparison.
Because the very GAO, I used to live just almost next door to the GAO when I lived in DC, and I love the GAO and the work they do overall. But the very GAO, some years back, did a study on that all the GME money is actually not used. There's actually leftover money each year, and they proposed that money go to actually NP and PA programs. Now the GME programs say they don't get enough, and I'm sure they don't get enough for their residency programs, but it's just interesting that, GAO had done that study showing of the excess of GME money at the end of any given fiscal year, a series of fiscal year. And their suggestion was to put it into nurse training programs. But thanks for your answer, Dr. Roth. I think Dr. Cook, I didn't mean to cut you off. You were saying.
No, I was going to say there is a nurse residency program that's sponsored through the Office of Academic Affiliations, but that is only for post-baccalaureate nurses. And they are trainees, so they receive a stipend as compared to the ONS program, which the residents are employees. So they're working full time, they're getting all their benefits. So theoretically, you would at least know how much money the Office of Academic Affiliations is spending on the programs, but it would be very challenging to determine how much is being spent on the ONS programs. But it's a good question. I think something, worthwhile considering about how you might capture that information.
Okay, Dean Montoya, do you have a question?
Yes, I just wanted to point out, I was so impressed with the first slides that you gave. This is actually in relation to what Dr. Damron is saying. It looked to me like, I can't remember which slide it was, but it was like extremely successful in terms of retention of nurses. And so right there, as soon as I saw that slide, because I'm like Dr. Damron and I are always about the money, because when you're in administration, people come to you and they give you an idea and they want you to do this. And the first thing we got to say is, how is this? How can we afford this? But it seems to me from that slide that to me was so remarkable that I don't understand why it wouldn't blossom even more than this and even outside of the VA, because, we have, For example, we have Presbyterian Hospital here that is starting an LPN program from, contracted with somebody for that. If you see that kind of result financially, my goodness, it seems to me you would absolutely put that in place. Now, they do have a residency program already, but it just seems to me that almost everybody should be doing this, and not everybody is.
Thank you very much for those questions. I think that many more people are doing it now because they've done the business case analysis and they're realizing that if they have these programs that the nurses are staying. So even though I was working for VA from 2007, I wasn't involved in the development of the RNTTP program. So I don't know the conversations around funding and how to support it. When I did a business case analysis in, I think it was 2017, I worked with the budget people and we put together a simple formula, and we came up with the number 426 million that the agency was losing from turnover. So we put that information forward in terms of requesting funding, and again, I don't know what the discussions were at the senior levels. And I think the COVID pandemic, in addition to the aging of the nursing population and the competition with the non-federal sector, has just exacerbated the nursing shortage and the need for nurses within the VHA. Dr. Roth, would you like to?
No, I completely agree. And we are currently at the Office of Nursing Services looking at retention rates further out. So we have a lot of the 1 year, did they stay past that first year? But we really want to look at retention at, the 3 year, the 5 year, 7, 10, are they staying long-term? And so we are in the development of a retention dashboard to be able to track that data beyond the first and kind of second year into that third and fifth year. So I think that'll be even more telling that we can really show for more of a business case that these residents really do stay beyond and are getting that initial, education, orientation, protected time to transition into practice and feel comfortable in that, becoming that professional nurse.
Thank you. We have another question. Olinka, am I saying that correctly? I apologize if I'm not.
Yes.
Okay.
Great presentation. I work for Indian Health Service, so I was really interested, and I've been trying to ask our agency, our headquarters agency, for something like this for our agency, but there's just no, I used to work for the VA, so I like the standardization that you all have. We don't have that in my agency. So for something like me, or someone like me, because I'm the nurse consultant for an area, what would you suggest be the starting point? Because first of all, we don't have the funding. Our recruitment numbers are in the toilet. And so what we're looking for, the nurses that we get are usually the nurses that go to nursing school and go back to their communities. And again, another thing that's our issue is a majority of the clinic or facilities that I work with are ambulatory. We only have one inpatient. So a lot of our managers are kind of a little nervous about hiring new grads into that ambulatory site, where I kind of am trying to think out of the box. But anyway, so where would you start if you were me with nothing and I have no resources? I've asked for help from my agency, but really we don't have anything like this.
Do you want to start, Dr. Roth?
I'll let you start. You built the program. I'll let you start and I'll add.
Okay, so I used to work for the Indian Health Service, and I know that they had they didn't have a transition program for new graduates, but they used to have 3 excellent programs for nurses who wanted to go into a different field of a different specialty field. So they used to have an OBGYN internship program. They had one for the ICU and they had one for the OR. I don't know if any of those records are around. So what I would say is everything that we've developed is in the public domain. So one thing that you could consider would be, I can give you the name of we could get you the name of the person to request the program information. We should be able to provide you the whole curriculum and the resident competency assessment form and all of the forms that we're using. I would also say that if you were to do a literature search, and I'd be happy to help you with this, there are, I know that I've seen in the literature residency programs for outpatient and ambulatory care units. So you could take a look at those, see what their programs have consisted of and what you might be able to implement within IHS. Does that answer your question?
Yes, thank you very much.
And Dr. Roth, did you want to?
Oh, I don't have anything to add. I would agree.
Perfect. Thank you. Do we have any other questions? Okay. Well, before we move on with our program, I want to first thank Dr. Coig and Dr. Roth again for sharing their expertise with us tonight. We greatly appreciate it. I also want to remind those of you in the audience to please sign into the chat with your name and your credentials if you haven't already done so. And also, please be sure to complete the survey in the chat by June 16th at 5 p.m. to receive your CEs. Again, we'll put that link in the chat right now. If we could not answer your question, or if you have another question that you think of later, you're welcome to contact our presenters directly. Their emails are on the screen, and we'll also put their emails in the chat for you. Okay. So thank you everyone for attending the UNM College of Nursing Research and Speaker Series. Be sure to visit our website for more information on our next lecture. Thank you, everybody.